All right, we'll go ahead and get started. Good afternoon. I am Dr. Williams with Regenexx Cayman. Thank you guys for reaching out and taking the time out of your busy and important day to join us for the webinar. So, I have the pleasure of discussing a very important topic with you regarding stem cell therapy for orthopedic injuries. So, we'll go over a couple of different things and just some housekeeping points. If you guys have any questions or comments, that's great. I look forward to addressing them. During the actual call here, if you want to put your questions directly into the chat, we'll have some time at the end of the webinar for a Q&A as well. If you do have anything pressing or if there's any IT issues, please feel free to throw up your hand with the button on the actual webinar here and by raising your hand to interrupt us if we need to address any IT issues with sound or audio visual. Okay. All right. So we'll go ahead and dive in here. So here's a kind of a summary of what we're going to be jumping into for about the next 30 minutes or so for the presentation. Then we'll have a designated time for Q&A at the end also. So who's this presentation geared towards? Any of these different bullet points here, if they are something that you struggle with, deal with, or that touches near or resonates near and dear to your heart, this is for you, right? So anybody that's dealing with chronic joint pain or injury related to your back, your spine, your joints, your ligaments, your tendons, if you have an acute issue that you're dealing with that is preventing you from doing certain activities, sports related activities, overall quality of life, or if you're trying to gain an advantage, if you're an athlete trying to gain a performance advantage, this is something that may be of interest to you as well. Or for people that are completely healthy and trying to take a more proactive approach or that are interested in stem cell banking, this presentation will definitely be helpful to provide some additional information for you as well. Also, so we look forward to jumping into the different nuanced things about stem cell therapy for orthopedics and being able to touch on all the different topics. So what's Regenexx? Regenexx has been around for quite some time. Regenexx is a global leader in stem cell therapy. Regenexx actually did the first stem cell therapy for knee arthritis in the world back in 2005. We did also the first stem cell therapy injection for disc degeneration into an intradiscal approach back in 2006 and started doing stem cell therapy with culture expanded stem cells at that point in time and have been doing culture expanded stem cells with our site here at the Cayman Islands at Grand Cayman since 2011. So we have well over 100 different providers and locations throughout the world, but we are the only site that does culture expansion with stem cells where we grow your own stem cells out of all of those 100 sites that are located throughout the world. We've published a lot of research. We really pride and really know the importance of publications and looking at the science behind these therapies to figure out who this technology works for, who it doesn't work for, and how do we make the technology better. So at this point, we've published about 44% of all the research related to stem cell therapy for orthopedics. And also, we have a very strong relationship in the United States with corporations that are self-funded. So we have about 200 self-funded employers that have brought on Regenexx to their benefits, their health benefits plan, and provide covered benefits to over 2 million employees that covers these procedures, whether it be PRP or stem cell therapy for orthopedic issues, as well, because of the cost savings and the outcomes that we've been able to demonstrate going back to the research and outcomes as well, which is the first of its kind as well to have that covered by an insurance company. So who am I? I am the medical director at Regenexx Cayman. Been working at Regenexx Cayman since roughly about 2016, I believe, so the past decade or so. I am originally from Jacksonville, Florida. Did my medical training after I went to the Air Force right out of high school, so I'm an Air Force veteran. I've done all of my medical training at Emory University in Atlanta, residency, was chief resident there as well, did fellowship training at Centennial Phillips Clinic in Colorado, where we did a focus in on interventional pain management, sports medicine, and regenerative medicine. Worked on staff there for a year, and then after that, opened up my own private practice in Atlanta. Have had that practice since 2017 as well. And also in faculty at Emory University, where I work with the residents, do teaching, also. I'm one of several doctors that work here at the Cayman site that are highly qualified, fellowship trained specialists that focus in on musculoskeletal regenerative medicine and orthopedics as well. We only do this. We don't really specialize or have any inclination to do these treatments for other conditions such as, multiple sclerosis or erectile dysfunction. We really fine tune and focus in on our specialty, which is musculoskeletal expertise, and doing regenerative medicine treatments for those issues as well. So we'll jump into kind of the management of non-surgical injuries and issues in the musculoskeletal system of areas that can be treated. So this slide here is a good kind of broad picture of what we can treat. So when we break it down into different regions within the body or different pathological areas as well. So if you have spine conditions, we can treat a variable amount of different things, whether it be disc degeneration in the spine and the cervical, thoracic, lumbar spine, disc herniations, pinched nerves, tearing of the disc, as well as arthritis in the spine as well, which is some of the more common things. Or if you have an acute tear of a disc, we can treat those as well. When we look at the joints, the second most common area or most common joint that's treated, spine is probably the most common area, then joints, the knees for sure. Most people tend to suffer from knee osteoarthritis at some point in their lifetime. The older we get, it's a more common wear and tear mechanical problem that we tend to fall victim to. But we treat every large joint in the body and small joint as well, from knee arthritis, meniscus tears of the knee, tearing of the labrum in the hip and the shoulder, rotator cuff tears of the shoulders as well. And also, if you have issues with some of the smaller joints, like the CMC joint of the thumb, at the base of the thumb is the most common joint in the body to get arthritis, having things like carpal tunnel syndrome, cubital tunnel syndrome at the elbow, impingement, trigger finger, tendonitis, in terms of tennis elbow, golfer's elbow, are very common as well, or even some other soft tissue injuries that we may see in athletes, such as an ACL tear, PCL tear, as well, are very common also. But we treat the whole spectrum. So everything, whether it be from an instability standpoint, or you have arthritis, or you've torn soft tissue as well, we can help you manage this and get you back to having good quality of life as well. So now let's segue into biologics. So what are the different types of biological therapies that we can utilize? And these are really going to focus in on autologous therapies, meaning therapies that you derive from your own blood or tissues. So PRP is just platelet-rich plasma. PRP is the oldest studied biologic therapy for musculoskeletal injuries. And, PRP is derived from the blood. So what that means is that when you have an injury, we can take some of your blood from a vein, and blood contains red blood cells, white blood cells, plasma, and platelets. And platelets are one of the initial healing cells in the body when you have an injury. They're like a first responder. The best example I always talk to patients about is that if I was running down the street outside, I fell down and I scraped my knee up, the first thing that happens is I'm going to bleed, and then I'm going to get a scab that forms. And that scab is 100% platelets. Those platelets then produce about 2,000 different growth factors, cytokines, and exosomes that promote tissue healing and regeneration. So that way, in 2 to 3 weeks, when that scab comes off, the tissue underneath is healed. The problem with the musculoskeletal system that we know is that most of the tissues in the musculoskeletal system have very poor blood flow to no blood flow. For example, the cartilage has no blood flow. It gets its nutrients from the underlying bone and the surrounding synovial tissue. The meniscus, only the outer third has blood flow. The disc in the spine, no blood flow. So when you tear or injure a lot of these different areas, they turn into chronic degenerative problems that just don't heal. So the premise with the PRP is that if we can take the platelets and concentrate them to a very high number and then precisely inject them to where you have damaged tissue at, you can get a healing response to occur. The two biggest caveats with that is that you have to have the appropriate dose, and also it has to be precise. So the dosing issue is that what we find is when you look at the data and the literature on PRP, when you see studies that come out that shows that PRP doesn't work, 90% of the time when you do a deeper dive into that study, it's because the dose is inadequate or inappropriate for that tissue. So what that means is that a good example is if I have a fever, I can't take an infant's dose of Tylenol for it to work. It's not the appropriate dose. And we know that as well, if you don't have enough platelets to treat, say, knee arthritis, then you're not going to get a good therapeutic response, or the therapeutic response is going to be very short term or very minute. So we need to have the appropriate dose, and so that's where Regenexx technology comes in. Is we take a very specific approach to determining the dosage based on the patient's age and how severe the issue is, and we concentrate in a laboratory. We don't just use a bedside kit. We have a specific laboratory protocol that we can go up to 10 to 14 to 20 times the concentration to make sure we're able to get you the appropriate dose to have a good response. So that's that. And then the second issue is precision, right? We know that when you inject things blindly, the outcomes just are not good. Research has shown that over and over again, when you take a traditional approach, as we used to do 30 years ago, when we did not have ultrasound and use anatomic landmarks to inject things like the knee or tendons or shoulders or joints, the outcomes are not as good as when you are using something like a high definition ultrasound. That may not matter as much if you're injecting someone with steroids because it has a more diffuse kind of effect and can distribute into the localized tissue. And it's going to be a temporary benefit, anyways. But when we're trying to get tissue to heal, precision matters. And so we use ultrasound, high definition ultrasound, and live x ray called the fluoroscopy machine to be able to see the tissue in real time, see the needles in real time to make sure we can get the product where it needs to go at. So that's really some of the most important things when we talk about PRP. Stem cells. So there's cultured and non-cultured stem cells. We talk about non-cultured stem cells is what we do in the United States. And we consider that to be our same day stem cell procedure because the FDA regulates that differently. And they say that you cannot culture or store that stem cell product, and you can only do no more than minimal manipulation. What that means is that you can spin it in the centrifuge and maybe rinse it, and that's really it. Then you have to use it within a certain time period. Typically, that's within 24-hour time period. And typically, that's going to be either your bone marrow or adipose or fat tissue that's going to be used for that. These procedures can be very helpful with treating a host of different orthopedic issues from knee arthritis to rotator cuff tears or ACL tears or disc degenerative conditions in the spine. But there is a limit because we can only take so much tissue. So you're going to be limited to how many different areas you can treat. And also, as we know that when we get older, the quantity of the stem cells that we have in our body decreases with age. So we have some limitations with age where the culture stem cell treatment may be more appropriate, or if we're treating multiple different areas within the body, may be more appropriate as well. Next, we have the Regenexx C procedure, which stands for Regenexx culture. What that means is that we're culturing or growing in a laboratory your cells to grow them to millions of cells. So what that looks like is that we can do that from bone marrow or adipose or fat tissue. And typically that's bone marrow because it's been tried and true and studied significantly more and longer term than adipose tissue. And we take your bone marrow in a laboratory, we take out the mesenchymal stem cell from that, and then in the lab, we're able to grow that to millions of cells. In comparison to when we do the non-cultured stem cell procedure, we roughly are injecting with the non-cultured procedure about 100,000 stem cells for a healthy adult patient. When we do the stem cell cultured procedure for a knee, for example, we're typically going to be injecting about 50 million stem cells for that particular issue. And that can have significant impacts and implication on healing and therapeutic potential. As we talk back about dosing with PRP, there's a dosing threshold that we know of as well for stem cell therapy. So this allows us to actually be able to grow the cells, and we can treat more than one area at a time where we have that limitation with the non-cultured product, the same day stem cell procedure, where we're limited to be able to only treat one or maybe two at most different areas, where with the stem cell cultured procedure, we can treat multiple areas at the same time because we have that many more stem cells. Banking is another good thing. We briefly mentioned that at the start of the presentation, but stem cell banking means is that you come, we do a bone marrow aspiration, but you're doing great. You don't necessarily have any acute or chronic injuries that you're dealing with. Sometimes this may be athletes as well. And we store the cells for future use. And what that means is that when you have an issue that comes up down the line, whether that be 1 year, 15 years later, we have your cells ready and able to be utilized at that point in time for treatment. So stem cell banking is great for anybody that wants to have a leg up on and being able to store their cells for future use. Okay, we talked about that a little bit, but let's talk a little bit about the difference as well, which we dived into of having more cells when we do the culture expanded stem cell procedure versus the non-cultured. It's roughly 100 to 1,000 times more cells, which means that when we have more cells, we can treat more areas. We can get a better therapeutic dose for the areas that we treat, and also, we can then bank cells that we don't use for future treatments as well. So, those are the different benefits with the culture stem cell product as well. We also know that dosing matters also. Here are some clinical examples that we'll go through of different body parts that we have pre and post treatment that shows you the therapeutic potential of healing with these products. So initially, there is some thought of when we inject stem cell therapy, what is it doing? Is it just modulating or modifying inflammation? Does it actually cause the tissues to heal, or does it do a little bit of both? So now that we have, years of data and more research has been done, we actually know that we're having a combination of things that are happening. We know that when we do these stem cell therapy treatments, they're like packets of messenger medicinal molecules that go out and modulate inflammation, tell the body what to do, what not to do. But then also we get repair mechanisms that are turned on cellularly as well, where tissue can become healed. And stem cells are immature cells that have the highest healing potential because they can turn into new tissue. So we do see some actual repair mechanisms going on and not just modification of inflammation, which is really the key differentiation of things like steroids. So this is a patient that we treated their low back. It's actually a European professional basketball player that was having acute radicular pain with, she was 35 at this point in time, I believe, and had a large disc herniation that we were able to identify on MRI. And what we see is that pre-treatment, the disc herniation was actually very large here. And then what we were able to do is treat comprehensively the low back, the lumbar spine at the L405, L5S1 level. And then post-treatment, this was actually taken about 3 months post-treatment, I believe. And then what we were able to see is that there was a almost complete resolution of the disc herniation as well, and significant improvement. He has been doing great. Got about 5 to 6 years of improvement, back to playing basketball, and functionally, he's very pleased and happy. So we can see these structural changes that can happen after these treatments as well, which is very impressive. So this is another example here of someone's shoulder. This patient had a very large actual tear of the supraspinatus tendon, as we can see here where the arrow is pointing. The white denotes a complete tear of the tendon. The white back here is some fluid that we have in the bursa. This would be considered to be subacromial bursitis with a large rotator cuff tear of the supraspinatus tendon here. And then what we can see is after treatment, we saw on post-treatment MRI that the tear of the rotator cuff tendon completely healed. But we also see resolution of the bursitis as well, which can be painful in of itself. But structurally, the most important thing is that we had complete resolution of the actual tear of the rotator cuff tendon as well. So very impressive outcome there where we're seeing structural healing of damaged tissue. This example here is a patient that had a labral tear. And so this is actually a hip. Here's what we call a sagittal view where we're looking at the hip directly from the side. This ball is of the ball and socketness of the joint. It's the femur, the head of the femur. It connects with the pelvis up here of the acetabulum. And here, this front triangle is visualization of the labrum. And the labrum is like a plunger. It actually suctions in the femoral head to hold it into place. And you can get over time, either from a traumatic injury or wear and tear, you can get a tear of the labrum, which is an example with this white dot with that circuit right there. And this patient had a stem cell treatment into the labrum, where we can see the resolution of the tearing of the labrum as well. All right, so let's talk a little bit about what's the difference between Regenexx procedures and surgical procedures, which I think is kind of important to distinguish the differences and similarities in some cases as well. So Regenexx procedures are all done in outpatient based in a procedural suite, not in the hospital, sometimes done in an ambulatory surgery center, but typically not. And why that is it helps us to keep costs down as well. So these are relatively safe when we look at the safety profile in terms of complication risks such as infection, bleeding, blood clot, tissue damage. It's less than 1% in comparison to the surgical counterpart, such as a total knee replacement, for example. As we mentioned, these procedures are needle based as well. When we also talk about pain post treatment, 9 times out of 10, you're going to walk out of the procedure after having a Regenexx procedure, whereas a surgical alternative, you may be non weight bearing or not be able to move the procedural site for 6 weeks after the therapy or treatment is done. So we have a very different approach. We know that motion is lotion. We try to get you back active and mobile as soon as possible to make sure that you are able to actually move the tissue for a good therapeutic response. When we look at the complication profile, we looked at that, and also the recovery. So these procedures, their procedure, but the recovery from the procedure is actually very quick overall. So we're talking about somewhere between 3 to 7 days of post-procedural pain management for a knee procedure. As an example, the surgical counterpart, for example, total knee replacement, it's going to be about 3 months where you may not be able to work and are dealing with a significant amount of rehab and recovery as well. And then we also talked about what's happening here in terms of the reparative and regenerative aspect of the tissue, whereas surgical counterpart here, we're removing the damaged tissue. When we talk about, as an example, the surgical counterpart to a knee procedure is going to be the total knee replacement for severe arthritis. And that's a joint amputation, essentially, is where we cut both ends of the bones off and put a metallic implant into the knee as well. And when we look at the data for total knee replacement, we know that about 33 to 35% of people after a total knee replacement, for example, still have chronic pain. So it's no one size fits all. There's no magic bullet out there. But we see when we compare it to a more non invasive approach, where we know that you can get several years, up to 15 years in some cases, of significant improvement after one stem cell therapy treatment for knee arthritis, there's a suitable alternative to help prevent you from going down that road of a joint replacement. So let's segue into this because this is usually a hot topic as well when I talk to patients about stem cell therapy. So anybody in the network that's looking as of interest for stem cell therapy with culture expanded stem cells throughout the world, you may be looking at Panama, Mexico, Costa Rica, Cayman. When you do your research, Cayman and Regenexx Cayman is probably going to be the most sought out location. Definitely has the most research. We're the only of these clinical sites that actually publish research as well. And then I always talk to patients because patients want to know, well, what's the difference in using umbilical versus your own stem cells, or why shouldn't I use younger stem cells from babies because I'm older, etc. So when we talk about stem cell therapy, the two most important things related to the cells, not the actual injection, is that's a different aspect we can get into here, are the quantity and quality of the cells. The quantity is very important because, as I mentioned, as we get older, our quantity of cells decrease significantly with age, right? So we know that a newborn versus an 18-year-old, there's probably over a million-fold less stem cells within the body, or million to a billion, depending on the person. And we know that, our rate of aging of our stem cells and the quantity that declines is variable depending on things that we're exposed to in life, some of the societal choices that we make, but also the genetics of it as well. But inevitably, everyone, as we age, our stem cell numbers decline with age. So that's quantity. And we're able to navigate around that by actually growing your stem cells. So we grow them to millions of cells so that way we can mitigate that decline with age to be able to adequately treat from a dosing standpoint multiple different areas. So then there's quality, right? So quality of stem cell is largely dependent upon the health of the individual. What that means is there's a genetic component to that, but for example, my patients that are smokers or tobacco users, we know that tobacco is extremely toxic to stem cells within the bone marrow. Heavy alcohol use is toxic to the bone marrow as well as a bone marrow suppressant. Some medications, if you are on chronic steroid or Medrol or methylprednisone or prednisone therapy, for example, for an autoimmune condition, your bone marrow quality may be negatively impacted. Or if you have certain health conditions as well, you may be limited in your ability to mount a cellular healing response as well. Also, so depending on the quantity and the quality, we know that there's significant difference between the two here. But then we look at outcomes, and what the literature does show is that when we look at outcomes of patients that use umbilical versus your own stem cells, that goes back to the two words we used earlier, allogeneic, meaning someone else is an autologous cellular therapy. We know that when we do allogeneic stem cell therapy from umbilical cells, the cells just don't last as long in the body. The cells are recognized as a foreign substance in a significant amount of people, and they're removed quicker. It's the same kind of thought process that happens when you actually have a kidney transplant, right? So if the match is not aligned, then you have an autoimmune rejection response as well. So we can see that that can happen. It's not as common with umbilical cells because the cells are so immature, but there are a large percentage of people that can have an autoimmune type of response to these cells as well. But we also know, particularly with knee arthritis, when you look at the outcomes of how well do these cells work long term, when you look at umbilical versus bone marrow versus fat cells, umbilical cells have the least response rate that's clinical therapeutic. So meaning they do less, they have less improvement and don't do as well in the long term as when you use your own stem cells. That's what we've been able to see from the literature. The only other caveat I'll say about this when my patients are considering having stem cell therapy done at other locations, the expertise of who's doing the treatment matters. So what you want to avoid is going to a location that's bussing you in. You don't even get to talk to a doctor or provider. You're dealing with a nurse practitioner or a physician assistant in a foreign country, and they just want to see an X-ray. They don't use any image guidance as well, and they're not expertly trained on how to do and manage these issues, right? Because we know that precision matters, as we talked about earlier. This is precision medicine. And so if you are not working with a highly skilled and highly trained provider, the likelihood that you're going to have significant long-term benefit is probably going to be a lot lower as well. So that's very important. Who's doing the treatments and what are their credentials? All right, so we can segue a little bit into what happens afterwards. So after we do these treatments, we give every patient a rehabilitation protocol. And what that means is that we give you usually a one-page sheet that's broken down into 4 phases of the recovery. Day 0 to day 3, day 4 to day 10, etc. And it tells you in each phase what activities you can do, what you should be doing, what you can't do, and when you can move on to the next phase. And so we give you this so that way you can share it with your physical therapist, because we know that physical therapy post-treatment is critical. You ended up with an orthopedic injury for a reason. We know that biomechanics matter. So we want to address the biomechanics for long-term success. If we don't address the biomechanics, your issue will resurface at some point in time because you have a biomechanical issue either that led to your issue or you develop probably abnormal biomechanical compensation strategies. I see it all the time. Patients tell me, oh, my left knee has severe arthritis. Now, over the past 2 weeks, my right hip is hurting because you've altered the way that you move and move the other limb as well. So with that being said, it's very important that when we meet you for the first time, we spend a significant amount of time with you looking at your entire biomechanical chain. If you come in with knee pain, we want to examine your low back, your hip, your ankle to see how these tissues are interacting together. So that way, if we are not just focusing so intently on the knee, but we look at the whole chain to see what structural other issues may be contributing to your issue as well. And then, as I mentioned, this is not surgical, so we don't have as long of a recovery period. It may be about a week of significant discomfort related to the procedure. Then we have you starting some physical therapy at about 2 weeks out. We typically have a follow-up at about the 2.5 month mark to check in on your recovery. And usually by that 6 to 8 week point, most people are back to doing significant sport related activities that they're interested in, whether that be golf, tennis, pickleball, etc. And most people are doing well and having significant improvement for years to come. So, why patients choose Regenexx? I think that you probably can tell I'm very passionate about this, and we've talked about these things, but there's several list of reasons, including the precision of what we're treating, meaning that you have a highly skilled and highly qualified doctor that's U.S. trained, U.S. board certified, that is an expert at what they do. We're able to treat several different areas because we are able to culture expand the cells, and we have a good dosing strategy, and also we have good follow-up. I think also it's important is we also focus in on outcomes and research. We're not just treating you and then you never hear from us again. When we treat you, we ask you to participate in our research registry. So that way, over time, over the years, as your treatment is going by, we can then get feedback from you and publish that data and say, hey, this patient did fantastic. Let's look at similar types of patients and see why they were able to do so good, or this patient didn't do so great, and why is that? And we can tailor things and modify the treatment to make sure we're giving patients the opportunity to have the best outcomes as well. And banking stem cells is great. And then being down and doing procedures and coming down to have a procedure done in the Cayman Islands is not a bad thing. As well as one of the great locations in the world that you can have a procedure done. It's very safe. They have every degree of tier level of hotel accommodation that you can desire, from the Ritz to the West End to the Hampton. Also, and it's culinary delight as well. So that's always a positive. We've treated several professional athletes. This is just one. And if you go to our YouTube page, you can just type in Regenexx and Ryan Tannehill, Miami Dolphins quarterback, and he can attest for his success with the procedure and his experience as well, which I think is helpful. And then also we do telehealth consults also. So when we have a large percentage of our patients that are getting these treatments done are coming in, we spend a lot of time with you. And what that means is we set up a telehealth visit where we're talking via Zoom as you and I are right now. We go over your MRIs. I will show you the picture as doing a screen share as I'm showing you the actual PowerPoint. I'll do a screen share to show you the actual MRI images and go through the MRI with you so that you see what I see and know what I know about your pathology. And then we talk about next steps and candidacy as well. So it's very important for us to have a better understanding of this also, but then also address your questions and concerns that you have about doing the stem cell procedure and talk about the things that go into candidacy also. And it's easy to set up a virtual health consultation. Also, we'll have some numbers, which are here, and also email addresses that are present here as well. So we'd love for you to reach out to us. I'm happy to chat with you, talk about your issues between that yourself or your loved ones or friends are experiencing, and see if this is something that may be appropriate for you. So thank you guys so much for your attention. And if you want to know more about one thing before we jump into the Q&A, if you want to know more about research, please visit our website, regenexcayman.ky. And we have a research section that goes over all of the publications that we've published. I'm always doing more research. We have 3 pending publications now. We've published 3 publications within the past 6 months as well also. So let's see if we have any particular questions here. And please continue to put more questions in the Q&A section, and I will go through these one by one. All right, so the first one that I have here is Dr. Hernigou's protocol on implementing it in the Cayman Islands. Do you do subchondral bone injections, and how long until you might see some impact for severely arthritic knees? So yes, we've been doing intraosseous or subchondral injections since 2017 as well. So, Dr. Felipe Hernigou is a French orthopedic surgeon that pioneered some of the subchondral injection techniques that show that when you do subchondral or intraosseous bone injections, you're able to get significantly better outcomes instead of just injecting into the joint. In terms of at 15 years, he was able to show that 70% of people that had subchondral injections with stem cells, after one treatment, 70% of those patients still did not progress to need a knee replacement. So significant impact on how we were able to modify and improve patient outcomes. So Yes, we do that. After about 1 to 2 weeks, the acute pain post procedure is died down. And then at about the 6 to 8 week point, most patients are noting some significant improvement. And most improvement usually comes between the 3 month to 6 month mark, and then starting to plateau between 6 months to a year as well. But very good. Thank you so much for that. Next question. I have a right knee that's almost bone on bone. I've been told the knees are not good, not a good joint for stem cell therapy. Also, disc and facet and sacroiliac problems. Can stem cell help therapy help these areas? I've had over 20 orthopedic surgeons and do not want any more surgeries, I believe that says. So I'm not sure where you got the information from about the knees. You know, advanced knee arthritis is probably the most commonly published treatment therapy for stem cell therapy. We have done thousands of these treatment procedures over time, and it does work. It works quite consistently well. In terms of the spine, that's a very common issue that we treat, whether it be disc degeneration, facet arthritis, sacroiliac joint dysfunction as well. And these tend to do very great and very good and consistently good with biologic treatments as well. So happy to take a look and see if there's anything that we can do. Once you've had surgery, that does affect potentially your outcome, particularly if you've had hardware inserted. If you like, for example, if you have a lumbar fusion. But I'm happy to talk to you on a one-on-one basis to see if this is a treatment option that may be good for you. Thanks. All right, next question. Is it painful to remove the bone marrow? And are the injection of the stem cells elsewhere painful? Yes and yes. But in digging into that a little bit deeper, I've had a bone marrow aspiration twice. Pain is subjective, right? So meaning that I had my bone marrow aspirated with local numbing, no pain medication, and worked the rest of the day, just to see how it feels. So the spectrum is that 90% of people do great. For some people that i.e., have a needle phobia or very poor pain tolerance, we do have a spectrum of options to help deal with the pain. So we have local anesthesia, we have nitrous gas, we have conscious sedation with our nursing staff. We have 4 nurses that we perform this with. And then we also have an anesthesiologist that can come to administer IV sedation with propofol as well, so that way you're completely sleeping. So we have a suite of different options to make it as comfortable as possible. When we're doing the injections, depending on what we're treated, there is treating is some pain, and some things we actually require that you have IV sedation for. For example, when we treat into the subchondral space for bone marrow changes or with advanced arthritis, that's very painful. So we do require patients to have IV pain medication for the actual injection for that procedure. Good question. Was the shoulder injection a PRP or stem cell? So the rotator cuff example that I gave with complete healing, that was of stem cell therapy. You can get healing of partial tears with PRP if they're relatively small or if the tendon is just inflamed, what we call tendinopathy. If you have more than probably a 30 to 40% tear, you're probably looking at more of a stem cell therapy, because PRP can help, but it won't heal the tear. But what we've seen with stem cell therapy with larger tears, you can actually get full healing. And there's a study that came out by the same orthopedic surgeon, Felipe Hernigu, and what he wanted to see is, does stem cell therapy help prevent re-tears? And he took patients that had rotator cuff repair, and he injected some with stem cell therapy at the time of the repair, and those patients had a 0% re-tear rate. And what we know is that when you have large rotator cuff tears, even after surgery, the re-tear rate can be very high and up to 70% in some cases. Good question. All right, next question. It is my understanding that even stem cells do not regenerate cartilage. Is that true? Yes and no. So in a large percentage of people, there have been several papers that have demonstrated you can consistently see some regeneration of cartilage after cellular therapy. But the no part is that it's not a large percentage. What I will tell people is typically it's around about 15 to 20% regeneration of cartilage. Does that matter? What we know is that, as I mentioned earlier, cartilage actually has no nerve fibers. So when people are having pain, it's because of the subchondral bone is affected, and that's where you get the pain from, or you have tearing in the meniscus, or you have tearing in the ACL, or you have inflammation or synovitis of the tissue. All of these other things have nerve fibers, but the cartilage itself does not hurt. And so that's why it's very important to do a comprehensive treatment. So when we do someone's treatment for knee arthritis, for example, they're getting likely about 10 to 12 injections. We treat all the structures involved to make sure we can get this knee the best chance of having a good long-term outcome. Great question. Next one, missed some of the beginning of the webinar, but do you do exosomes as well? And would you use that versus stem cells? Have a family history of cancer, prostate cancer, and hearing the exosomes are a better path as well. So good question. So exosomal therapy is not legal to do. There's no exosomal products that are approved or legal to use per the FDA in the United States at this point in time. Here, when we do our treatments, we do exosomal therapy because the MSCs or stem cell therapy is an exosomal therapy treatment as well, and we add in platelet lysate, which is an exosomal therapy as well, also to get better growth factor release and also better regeneration of the tissue. But going to the second point about cancer history, personal or family, if you have a family history of cancer therapy, that's not a contraindication of cellular therapy or stem cell therapy. If you have a personal history of cancer therapy that has not been in remission for at least 2 years, that is a contraindication to do stem cell therapy. And what I always ask of my patients, even if you have been in remission for 5 years, always ask that you discuss this with your oncologist and get them to give you a note that is giving you the blessing to have actual cellular therapy done, which has not been a problem in the past. Good question. All right, next question. Do you offer umbilical cord stem cells at all? We are in the process of doing umbilical IV infusion stem cell therapy because we know that, and the research shows that IV stem cell therapy can be extremely powerful for a longevity tool. And so what that means is if you have systemic inflammation, things like multiple sclerosis, lupus, rheumatoid arthritis, Parkinson's disease, more total body illnesses, issues, or even COPD or asthma, you can have a significant implication to have a benefit from IV cellular therapy with the umbilical cord stem cells. But what the research has not shown is that there is going to be no benefit of injecting IV for a localized musculoskeletal problem. You have knee arthritis, doing IV stem cell therapy has not been shown to be effective at all for treating that. So we are trying to add in as a adjunct to treat multiple ways to get you the best chance of having long-term improvement from a longevity standpoint, but also from a musculoskeletal standpoint. And what that is and means is that, for your localized musculoskeletal things, we are doing the very highly precise culture expanded MSC treatment from your bone marrow and adding in IV umbilical cord therapy for longevity or systemic issues as well for that benefit, just to kind of give you the best of both worlds. Good question. Next question, what's the time frame for culturing of stem cells? That's a good one. So when you come down, we actually do the bone marrow aspiration, and then we culture the cells for about 3 weeks. And then at that point, they're placed in the cryopreservation. We send a small aliquot or small sample off for testing. We look at sterility, we look at viability, and endotoxin testing as well. We don't just keep letting the cells grow because that's essentially what a cancer cell is, right? Just unchecked cellular growth. So we freeze them to make sure they're frozen and safe. And then when you come back, they're ready to be used. And we grow them a little bit more when you come back. But very good job. And that's about 4 weeks from the time of doing the bone marrow aspiration. The soonest that we can get you back in most cases is about 4 weeks later to actually do the treatment. You can come back at any point in time, or if you just want to do it for cell banking, we can do that as well. Very good question. Next question, can you help a bone-on-bone hip? Yes, the severity of hip arthritis is very important. That's why for these types of cases, I really need to review the imaging to make sure, as we talked about, the hip being a ball and socket joint, right? If your hip arthritis has become so advanced that that ball or spherical shape of the femoral head has turned into a block, so we have a square peg and a round hole, then that's not going to be affected by the treatments that I do. There's nothing that I can inject that can change the shape of the femur head. But if you have a very good contour, even if it is bone on bone, you can have significant improvements from the type of treatments that I do. And what we do see is that when we compare what we do here to what we do in the United States with the non-cultured stem cells for severe hip arthritis, the outcomes are about 50% better as well. So Good question. Next question, is this procedure supportive of muscular dystrophy issues? Unfortunately, this procedure where we're talking about injecting for orthopedic issues, whereas muscular dystrophy is a neurological issue, is not going to have the impact. Now, IV stem cell therapy may be potentially of importance for that. So that will be kind of my direction that I'll recommend looking into for potential improvements or effect on muscular dystrophy. Good question. Next question, how do I set up a teleconference? All you have to do is email us at info@regenexcayman.ky or give us a call on the number that's on the screen as well, and we will be happy to chat with you, set up a call. I can speak with you directly about your particular issue. Thank you. Next question, what if you have biomechanical issues such as patellomel tracking? Can stem cell therapy help? Yes, absolutely. So we can treat the consequences of having patella maltracking, such as fraying and rubbing of the cartilage, inflammation, and damage of the joint. But with that being said, and we also treat the ligaments around the knee to help tighten the ligaments that support the kneecap so that way it tracks better. With that being said, it's very important that we work on the biomechanics and get you an appropriate physical therapy to work on strengthening of the quadriceps, activation of the gluteal muscles, as well to aid in tracking of the kneecap from a structural standpoint, so that way we can correct it as well for long-term success. Next question, will this be available to listen to again on your YouTube site or elsewhere? Yes, this will be posted on our YouTube page today for your viewing pleasure. Share with your friends, your family, and your loved ones. Next, the Japanese just came with products that can be targeted to become certain type of organ cells, starting with the heart and the pancreas. Any chance of developing that expertise? I saw that they have two recently approved stem cell therapies from induced pluripotent stem cells, which is very different than what we're talking about here. But that is not our expertise. Not to say that that's not some technology we may be able to bring on board in the future. But at this standpoint, it's very new, and we don't know the nuances of that or the long-term consequences and outcomes yet. So that's not something that we're bringing in-house at this point, but who knows what the future may hold. Very good question. Next question. Did you say there is a 15 to 20% success outcome of cartilage regeneration from stem cell therapy? And does that age impact that as well? So that's a nuance to kind of elaborate on. So 15 to 20% regeneration does not equate to 15 to 20% success. Cartilage regeneration does not define how well the knee does. So we can see that if you get 10% regeneration of cartilage, we can have somebody that has 80% improvement of knee function and pain and quality of life metrics. So we can see that from an MRI standpoint that there may be some 15% or so regeneration of cartilage, but that doesn't mean that the patient is only feeling 15% better, right? So age does not necessarily impact that. Severity of the arthritis for the knee does not necessarily impact that unless we have extremely severe arthritis where you've had multiple surgeries, you have no meniscus tissue left, you have no ACL tissue left. But for run-of-the-mill, advanced or severe arthritis of the knee, we know that that can do great for many years after one treatment, even if we only have 10 to 15% regeneration of the cartilage. So that's a very good point to elaborate on. All right, guys, it looks like I have finished all of the questions. I'm happy to hang tight here for just a second. If there are any more questions or anybody else would like to chime in, please raise your hand, and I'm happy to do a live question and answer if you would like to as well. But I definitely, with my sincerest thanks, I thank you guys for spending your time and taking the time out of your busy afternoon to jump on here and learn more about things that I love to talk about and things that I love. So please don't hesitate to reach out. The number there is there. The email is info@regenexcayman.ky. Happy to discuss your issues specifically with you and see if this is something that is a good fit for you as well. Okay, no more questions. Please take care of yourself and be safe. Thank you so much.